Hi everyone, I'm Dr. Akhila Ayyagari. Today we are going to talk about unexplained infertility. So to start with, infertility means inability to conceive after regular unexpected intercourse for a period of at least 1 year. Unexplained infertility is something that we don't know what is the actual cause of infertility. So in about 8 to 30% of couples, the ovarian reserve or ovulation is documented, semen analysis is normal, and the tubes are also patent. So when these three factors are met with and yet the couple is unable to conceive, these are the couples that who fall into the category of unexplained infertility. Now, let's quickly understand what are the causes of unexplained infertility. So, to start off with, ovulation is documented, semen analysis is normal, tubes are patent. So, the other causes which may cause fertility issues include genetic causes like chromosomal or gene abnormalities, or endocrine causes like thyroid, prolactin disorders, or abnormal sugars, and mild or minimal endometriosis can cause unexplained infertility. Also, borderline ovarian reserve. These are some of the causes of unexplained infertility. Also, immunological causes, that is AFLA, SLEs, ANA, abnormal values. These are some of the other conditions that a patient may come with normal ovulation, good semen analysis, tubes patent, yet they're not able to conceive. And how do we come to a diagnosis of these patients, importantly? So when we come to ovulation, the first thing that we need to check for, ovulation can be predicted if a woman is having regular cycles. So regular predictable cycles, that is if she can approximately tell when she's going to get her period and she gets her period regularly, that is one sign of ovulation. Also, the other tests include doing a prolactin level, doing a progesterone test about a week before she getting her period, or LH monitoring. These are some of the tests that can document ovulation. Now, apart from ovulation, we also need to know in these patients the ovarian reserve. How is the reserve of this patient, the egg count? So that is typically tested through blood or by a scan. A blood test includes AMH, anti-Mullerian hormone, that tells us about the number of eggs. Less than about 1 or 1.2, we normally think that the ovarian reserve is less. Also, when we do a scan, we can count the number of follicles. So these antral follicle count in an ultrasound also is a very good measure to know the number of eggs. About 4 to 6 on each side is considered to be a normal count. Anything less than 6 in total is a little abnormal, and borderline ovarian reserve, that is about 8 to 10 or these kind of total number of AFCs, these are the ones who actually fall under the category of unexplained infertility. This is when it comes to ovulation. Now, semen analysis, obviously we have a test. Within an abstinence of 2 to 5 days, we take the semen sample from the husband and look for the count, motility, and morphology. Should this be normal, then the couple is labeled as unexplained infertility. Any problems in the count or motility or morphology is something that needs to be treated. Now, the last is the tube test. So, tube test can be done by essentially 3 methods. One, traditionally what we do is a hysterosalpingogram. Laparoscopy also can be done, and a saline sonogram. So, HSG, that is hysterosalpingogram, is we pass in a dye, a radio opaque dye, and that delineates the uterus and the tubes as well. So, we get to know that the tubes are patent, and we get to know the contour of the uterus as well. This is HSG. Normally it is performed before day 10 or day 12 of the cycle. And laparoscopy is confirmatory. We put in a scope and then we check for the tubal patency, how the tubes are, how the uterus is. Laparoscopy is invasive. HSG is relatively cheap and non-invasive. So there is another test called as saline sonogram, wherein it's an ultrasound guided procedure. We send in the saline and free fluid can be seen in the POD. So now we wouldn't know which tube is it unilateral or bilaterally patent is something we wouldn't know with this test. So HSG and or laparoscopy is better than saline sono. Though all three of these tests can be done to check for tubal patency. Now these are the three main important criteria that we have. That is to document ovulation, and semen analysis should be normal, tube should be patent. Once these three are established, this couple is labeled as unexplained infertility. Now, what are the treatment options that we have for these kind of couples? One, if the couple is young, the woman, and they're married for less than 1 year or maybe 1 to 2 years, if everything is normal, and they can still try expectant management, that is try naturally, or if they've been trying for more than 1 or 2 years and the female age is on the higher side, IUI can be offered to these people, that is ovulation induction with IUI. And this ovulation induction with IUI is a process in which the gamete density is increased. That is, with letrozole, we increase the number of eggs that are ovulating. So superovulation is what we are expecting, along with the processing of the sperm, wherein the sperm is processed and the good sperm is taken and it is put into the uterus. This is IUI. So this also can be offered as the first line of treatment. The last modality would be IVF. After about 3 to 4 cycles of failed IUIs, then we can offer the couple IVF, and with a success rate of about maybe 40 to 50%. This is the next step to treatment of unexplained infertility. So this in brief is all about unexplained infertility. We've discussed about the causes, the diagnosis, and how the treatment is offered to these couples. So I have a few questions. The first question is, my sister has PCO, but she was ovulating normally after weight loss. Currently, she's taking Clomid. She's trying to conceive for a year and tried medications that didn't work. Will she conceive soon? So PCO is totally a different topic, but yes, there is no doubt that she can conceive. And normally these ovulation induction drugs, that is letrozole or clomiphene clomid, we usually give for a period of 1 year and not beyond. So we need to also check for the semen analysis of the husband, whether that is normal or abnormal is something that needs to be checked. And accordingly, we can proceed. If they've been trying naturally, IUI can be attempted for 1 or 2 cycles. The next question is, I'm 33, trying to conceive for a year, regular ovulation. Clomid again was given for ovulation. We are waiting every month and helpless. Please help us. So again, the same thing, the plan of action would be to make sure that the tubes are tested, semen analysis is done. If everything is normal, we can try IUI for 1 or 2 cycles and then proceed for IVF. Normally, IUI is usually done for 3 or 4 cycles, but since you've been taking Clomid for quite some time, and normally we don't give ovulation induction drugs for more than a year, so that is why I've kept it to maybe 2 cycles of IUI. If everything is well, we can also take, we can do a hysterolaparoscopy and check how the uterus and the tubes are, and proceed for another 1 or 2 cycles of IUI as well. So that is the appropriate apt management for that patient who is 33 years old. Next question is, I retrieved my eggs in multiple retrievals, but only a few were mature and fertilized during both of my retrievals. Adding a growth hormone didn't help. What treatment can be done? Please suggest. So when it comes to egg maturity, What typically we do is we try to change the protocol and the injections used in the next cycle. Not that what was done in the first cycle was wrong, but it did not give an appropriate result. So growth hormone, adding steroids definitely helps in trying to get mature eggs. And also the trigger, what we give, the trigger injections, that usually changes the time at which we are doing the pickup, also needs to be changed. So these are some of the changes that we do in the next cycle to increase the number of mature eggs. My friend and her husband consulted various hospitals. Doctors went through numerous tests. All came positive, but they couldn't conceive yet. Is there any treatment to conceive? So this actually needs to look into all the tests that were done and what treatment was already offered, and the age of the patient, the number of years that they're married for. These are the two important prognostic factors that we need to consider. Looking at all this, we can definitely offer IUI or IVF based on the tests and the prognostic factors that I have just mentioned. Next question, please. Is it possible to experience unexplained infertility even after undergoing laparoscopy? Yes. So this is the thing. In laparoscopy, we can tell that the tubes are patent, and that is the test for tubal patency. So we can establish that, and if the ovulation is documented, ovarian reserve is good, semen analysis is normal, you still definitely fall into the category of unexplained infertility. Next question, please.